I'm presenting my presentation. Is it seen? My presentation is seen?
Yes, yes.
Sir, it's getting loaded.
Yes.
You have to double click.
Respected senior and my dear colleagues, I, Dr. Shah, President for Maharashtra chapter, on behalf of the National Society of Manual Small and Cataract Surgery, I welcome all the speakers and delegates for this wonderful series of webinar that is A to Z of Manual Small and Cataract Surgery. Today is episode 14, part 1, and the topic for today's discussion is personalized approach to SICS and nucleus management, unveiling diverse perspective. The aim of our webinar is to popularize smart SICS. It should be safe, cost-effective with minimum learning curve, and it should be useful for community basis. There are a few important quotes which are very useful in personalized SICS management. In SICS, there is no one-size nucleate fit for all. A personalized approach is the key success to achieving the best outcome for each patient. Understanding the unique characteristic of nucleus is essential for tailored and effective nucleus management in SICS. The art of SICS lies in the surgeon's ability to adapt technique to specific need of patient, ensuring both precision and safety. Diverse perspective in nucleus management enrich our understanding and leads to innovation that improves patient care. A surgeon's ability in nucleus management reflects their mastery of SICS and their commitment to personalized patient care. Here are few photos and diagrams which are useful for personalized approach to SICS and nucleus management. For this wonderful series of webinar, we have chairperson Dr. Prakash Marathe, Dr. Santosh Agrawal, Dr. Inder Mohan Rostagi, and the speakers for the topic, that is personalized approach to SICS and nucleus management, unveiling diverse perspective. We have speakers who are expert in their field with the best of their knowledge and experience. Dr. Sunil Thangaraj, Dr. Pradeep Mohanta, Dr. Ranjit Dhariwal, Dr. Shekhar Paranspe, and Dr. Sanjay Tekawade.
And discussion who will discuss this who will discuss this topic, we have Dr. Rohan Chariwala, Dr. Satish Sheth.
I am thankful to all the speakers.
1 minute. I will go back. 1 minute.
And the speakers for the topic. For this webinar, we have discussant who will argue, debate and dialogue. We have Dr. Rohan Chariwala, Dr. Satish Sheth, Dr. Ruchita Machwe, Dr. Gonenzilo Algendrio Uruta Jara. I am thankful to all the speakers and delegates for sparing their important and valuable time and making this webinar a grand success. Thank you.
I will hand over to Aarti for the discussion.
Good evening, everyone. We welcome you all to this wonderful episode of another learning episode of Maharashtra chapter of ISMSICS. We have with us Dr. Jagannath Boramani sir, who is Executive Chairman of ISMSICS, We would like to hear from you, sir.
Yeah, good evening, all of you. I don't want to waste your time, but I just have a very sweet announcement. ISMSICS is increasing with leaps and bounds all over the globe. Very recently, we had a zonal conference in Mumbai, which was a single hall and focus conference. But I'm very glad to announce that Dr. Gonzalo is with us today. And with the short notice, within 2-3 days, he has formed the Latin American chapter of ISMSICS with almost 16 office bearers. And we'll be having the virtual launching of the Latin American chapter of ISMSICS within a fortnight. Very soon, we'll be declaring the date. Thank you very much.
Thank you so much, sir. We have with us Dr. Prakash Marathe, sir, who is Chairman of Maharashtra chapter of ISMSICS. Over to you, Marathe, sir.
Good evening, everyone. As the chairman of Maharashtra chapter of ISMSICS, I welcome everyone, all the speakers, presenters, chairpersons, discussants, and office bearers of ISMSICS, along with our international Dr. Gonzalo. Welcome to him. This is the wonderful webinar and special efforts being taken by our president, Dr. Anil Shah. This series has been continued for almost more than a year now. With the success of Maharashtra chapter, along with this webinar, as Dr. Boramani has announced that there was the wonderful West Zone conference at Geo World Convention Center in Mumbai a couple of weeks ago, and it was the grand success. I think today's webinar is a wonderful thing. As Dr. Anil Shah has said, nucleus management is the important step in SICS. And I think there are various techniques. So there are various videos presented by special stalwarts here, and their technique will be presented in this particular webinar, and definitely all the attendees will be benefited by this. And I wish grand success for this particular webinar. Over to you, Dr. Arti. Thank you so much.
Thank you so much, sir. We have with us Dr. Anand Pangarkar, sir, who has joined us from Seattle, who is the Chair Scientific Committee of Maharashtra chapter of ISMSICS. Over to you, sir, for a few words.
Hello everyone.
Hello.
See, the best part is that this is the second webinar I'm attending from Seattle. Great lot of efforts by Anil Shah and the Maharashtra chapter, and I welcome the international speaker and the national speakers, and I'm sure this will all help us in learning different techniques of nucleus expression. All the best.
Thank you so much, sir. Your presence from Seattle indicates that we have been very consistent in our efforts. So I now would like to invite Dr. Ameya Kulkarni, who is Secretary of Maharashtra chapter of ISMSICS, and he'll be moderating this session with me. Over to Dr. Ameya.
Thank you, Dr. Arti. Good evening, everybody. All the office bearers of ISMSICS and the rest of the eminent panel. We'll just, I'll start with introducing our chairpersons today and the speakers so we can get to the nitty-gritties of today's discussions. Is my screen visible?
Yes, it is.
Okay, so we'll start with our very own Dr. Prakash Marathe. He's a consultant ophthalmologist at Netri Yogi Eye Clinic, Pune. He's also the past president of Maharashtra Ophthalmological Society, Pune Ophthalmological Society, and Indian Medical Association, Pune. He's a member, Legal Affairs and Expert Group Committee, AIOS. He's also chairman, Maharashtra chapter of ISMSICS. He's a past managing committee member, All India Ophthalmological Society. He's also the past senior vice president of IMA Maharashtra State. He's honorary secretary, Social Security Scheme, IMA Maharashtra State. He has won the President's Appreciation Award by National IMA Headquarters, New Delhi, twice, 18 and 22. President's Appreciation Award by IMA Maharashtra State for 2013, 14, 18, 20, 20, and 21. He also has President's Special Felicitation Award by IMA Maharashtra State for 2021. And he also has the late Dr. Asha Kelkar Award given by POS in 22. So welcome, sir.
Thank you so much. Thank you.
Our very own Dr. Anil Shah, sir. We call him our snare man. So he has various research awards. snare for MSICS, large foldable IL for MSICS, modified intracystic implant for DCR, and Best Research Private Practitioner Award. He has books and articles published on Manual Phaco Best Out of Waste, Master Guide for MSICS, Oculoplasty Made Easy, article for snare in AIOS journals. Then we go to Dr. Inder Mohan Rastogi. He's a dear friend who has done his MBBS, MS, FACS, FIAMS, and FAICO in comprehensive ophthalmology. He's a professor in HOD, Department of Ophthalmology. He's also director of Triveni Hospitals Private Limited. He's recognized as a PG teacher by NMC, and he has gold medals that has been bestowed upon him by ISMSICS, also gold medal by IRRSI. He has published more than 15 international publications, and he's a reviewer and editor of many journals. Welcome, sir. We also have Dr. Santosh Agarwal, who works at Sushila Netralaya and Laser Center in Sambhajinagar, Maharashtra. He is an MS Ophthalmology, a gold medalist. He's done DNB, and he's a Vitreoretina fellow from Shankar Netralaya, presently working as Vitreoretina laser ROP expert and phacosurgeon. He has a gold medalist in his MS University examination, is the best outgoing fellow at Shankara Netralaya, Chennai, best research award for new innovative techniques. He's won that many times in Nagpur 2013, Pune 2018, AIOC 2018, and AIOC 2024. Gold medal for outstanding work in the field of ophthalmology by BOA this year. He also has the Dr. Suresh Limaya Award in Moscow in 2019. And most of all, under his leadership, he is the president of MOS currently. Maharashtra Ophthalmological Society has been awarded the Best Overall State Society of India by AIOS. So, welcome, sir.
Thank you. Thank you very much.
We now move on to our speakers today. We have an eminent faculty. We have Dr. Sunil Tangraj. He's a comprehensive ophthalmology whose surgical work includes cataract, cornea, and glaucoma. He works in a rural eye care center in Sriram Nagar, Andhra Pradesh. He does a lot of charitable surgical programs in Myanmar and Africa as well, which primarily include surgical training of ophthalmologists there. I believe Dr. Aarti would know about this. She also works a lot in Africa. He hosts his own YouTube channel where he has posted around 700 videos. So welcome, Dr. Sunil. We have Dr. Pradeep Mohanta, sir. He is a DO resident from JIPMAR. He's done his MS Ophthalmology from PGI Chandigarh, and he's a VR fellow from Shankara Netralaya. He's also founder of Netrajyoti Eye Hospital, West Bengal. He's also founder of Helen Keller Blind Boys Rehabilitation Center in Anulia, West Bengal. And he's performed live surgeries in many national conferences, national and international speaker in many ophthalmic congresses, and has been teaching anterior segment ocular surgeries through his YouTube channel. He has more than 2,000 videos on his channel. Welcome, sir. We have our very own Dr. Shekhar Paranspe, sir. He's from the same town. I'm privileged to be from the same town that he's from. He comes from a long lineage of ophthalmic surgeons. His father was the first one to implant an intraocular lens in the country. Dr. Shekhar has worked tirelessly for the past 40 years, and he has various awards. And for us, we know Dr. Shekhar as a champion badminton player, and he's also a very avid alpine skier. I've never come across anybody with that hobby before, but sir is a fantastic alpine skier. So welcome, Dr. Shekhar. We also have Dr. Ranjit Dhaliwal. He's an editor of Video Atlas of Ophthalmic Surgeries, Master's Guide to Manual SICS, Ready Reckoner of Modern Ophthalmic Surgery, Video Atlas of Ophthalmology, MSICS e-newsletter. He's consultant anterior segment at Eye Infirmary, Nabha. So welcome, Dr. Ranjit Dhaliwal, sir. We have Dr. Sanjay Tekavade, who's from Pune. His graduation and post-graduation is done from BJ Medical Pune. Did his senior residency at Taparia Institute of Ophthalmology, Bombay Hospital, Mumbai. He is a member of European Society of Cataract and Refractive Surgery and American Society of Cataract and Refractive Surgery. He's done his fellowship at Moorfields Eye Hospital, London, and Queen's Hospital, East Grinstead, UK. He's been practicing for the last 30 years, specializing in phacoemulsification and refractive surgery. He has many international publications in ASCRS in 2004, 2005, ESCRS in 2018 and 2019 meetings. He was awarded by the Maharashtra Ophthalmological Society for Best Surgical Video in 2006 for the innovations in cataract surgery in 2010 and Best Video in its category in 2023. So with that, we come to a close for our introductions. I hand over to Dr. Aarti for further.
Thank you so much, Dr. Amaya. In interest of time, I may keep the introduction a little short from here onwards. So it's an honor to introduce today's discussants. We have with us Dr. Rohan Chariwala, who is practicing ophthalmologist and public health consultant and researcher. He did his master's in public health in eye care from University of London. He's invited regularly or as resource person. He's faculty on various clinical as well as community related fora. He has published many articles in national as well as international journals and co-authored many guidelines at national level. He is founder and chief medical director of Tapiba Eye Hospital and Research Institute managed by Shubham Netra Seva, a trust to serve in tribal areas of areas bordering Gujarat and Maharashtra state. So thank you so much, Dr. Rohan, for joining us. We have with us Dr. Satish Seth, sir, who is the owner of Distri Eye Care and Research Center in Hubli, and he is also the associate professor at KIMS in Hubli. We have with us Dr. Rujuta Machwe. She is a practicing ophthalmologist from Pune. We have with us our international discussant, Dr. Gonzalo. He is ophthalmologist from University of Chile. He is anterior segment surgeon who is trained in Barakar Institute of Barcelona. He has done his fellowship in cornea refractive and anterior segment, and he is currently working at Department of Cornea and Ocular Surface at Ophthalmedica Eye Clinic in city of Temuco in Chile. So thank you so much, Dr. Gonzalo, for being with us for this session. So without further delay, let's move on to the academic part of this session, and I would like to invite our first speaker for today, who is Dr. Sunil Tangaraj, sir. Over to you, sir, for your presentation. Sunil, sir, you're muted. So maybe till the time we have our first presenter ready, let's hear from our international discussion for today, Dr. Gonzalo. What is the status of manual small incision cataract surgery in your area? Please unmute yourself.
Yeah, okay, thank you. In our area, this technique is not very known. So we are forming the LATAM chapter to introduce and to show this technique to the other ophthalmologists from LATAM. You know, here we do most phacoemulsification, like our main technique, and the MSICS is just for complications. So it's so hard to see MSICS as first indication, you know.
Okay.
And our idea is change this a little bit and show this technique to our colleagues or the other ophthalmologists from LATAM.
Thank you so much. So, Dr. Sunil, till the time I just call him, I'll invite Anil Shah, sir, if it's okay, I invite Dr. Mohanta, sir, for his presentation. Sir, you are muted, sir.
Can invite, no? If the Pradeep Mohanta,
Yeah.
sir,
Yeah, so we invite Dr. Pradeep Mohanta, sir, for his presentation.
Yes. Sunil sir is leading, no problem.
Yeah, I'll try to put my presentation. Unfortunately, I had to change my laptops. So
Okay.
I ran into trouble.
Okay.
No problem, sir.
Yeah, just give me a minute. Start the video.
Sure.
I'll try to share from here.
Yeah.
They don't need my voice. Can you see the video?
Yes, sir. It's
Hello?
visible. Yes,
Yeah.
yes, it's visible.
You can see videos.
Okay, and you can hear me, right? Okay, now
Yes.
I'll start.
Though we
Okay.
can't see you, we can hear you.
Yeah. So basically, I'll be talking on hydro expression and two dialer technique. Now, the main prerequisites for these techniques are obviously you have to have a good wound architecture, a good rhexis, good hydro dissection. Okay, so that's the wound. Of course, it's a transconjunctival SICS. So just showing you, I'm not going to go much into this. A good wound architecture. Next, an adequate rhexis. I'm going to show you several examples and sort of I suppose you could get the technique from that. So that's a big rhexis, large enough rhexis, about 5.5. This is a very immature cataract, as you can see, and a hydrodissect. And watch this. I tilt one pole out, and I use the same hydrodissection hub needle and rotate the nucleus out right into the anterior chamber, pressurize with BSS itself. Okay, and then put a little bit of posterior scleral pressure, and out she comes. That's it. That's as simple as it gets. Okay, now I'm doing it in a harder cataract. Again, of course, you have to open up the incision. The rhexis is already done. Once you open up the incision, do your hydrodissection. Okay, the nucleus tilts up, tilt from the other side. Engage the pole and rotate it into the anterior chamber. All done, and pressurize with BSS. Okay, I just pull down on the limbus with my limbs and then give posterior scleral pressure, and it comes out. Now I'm showing in different cataracts. I'm showing in an intumescent mature cataract. Again, always very important, an adequate rhexis and a good wound architecture, key to the success. You don't need much hydrodissection here, and here when you go into a hypermature cataract or a Morgagnian cataract, difficult to hydrodissect. So you can see I'm struggling actually to engage that pole because there is no epinucleus to help me. Again, pressurize the chamber, and out she comes with just minimal posterior scleral pressure with the hydrodissection cannula itself. Watch where I'm putting the cannula, outside the external wound. And I keep moving backwards, and the nucleus keeps coming out. Sometimes I engage it and rotate it out. It can be used even in very hard cataracts like this. But you have to remember, you have to do an adequate rhexis. Get out that entire, you have to engage a pole. So I'm just watching for the pole. There it is. Engage that pole and just go underneath that and rotate it out. Again, pressurize the chamber with BSS, no visco here, and bring it out. And this is the last case for the hydrodissection. It's a very hard cataract, as you can see. And look how I have got the pole out. I have pressed on the iris and got out this pole. So sometimes you have to change. You have to watch where is the easiest access and which pole is easier to access. Again, rotate it out. This is a large nucleus, as you can see. Again, put in some BSS. Sometimes you could even put in viscoelastic. Here, this is exactly what I am doing. This is a combination of techniques. You don't have to just go ahead with one technique. I'm actually putting in viscoelastic also and pressurizing the chamber. And look what I do here. Again, combining another technique. Rather than just pushing in with my hydrodissection cannula or the visco cannula on the posterior sclera, I'm using actually a vectors, but I'm not going in fully. I just get out a pole, and once that's out, keep moving backwards till it comes out. So that's with the hydro expression. Now I go on to the next technique, which is my favorite technique. And this is the two dialer technique. Again, you need the same prerequisites: adequate wound, a good rhexis, good hydrodissection. And this works with any cataract, especially hard cataracts. Just watch. I've separated the capsulocortical adhesions. Now I go in with 2 dialers. I push to the left with 1 dialer, hook this pole and cartwheel the nucleus out into the anterior chamber. Then I sandwich it between both the dialers and bring it out. It's like chopsticks. Just bring it out with chops, like a chopstick. This even more difficult cataract. You can see this intumescent lens, hard nucleus. Just put in a lot of you need a lot of viscoelastic in these cases. Okay, go in with both. You need the technique. It has a learning curve. I'm sorry, what happened?
Your computer just shut down.
Computer just shut down. Can you watch this? I'm sorry.
So your screen share has stopped working now.
I don't know what's happening. I mean, you saw that one video.
The videos here.
Yes, we did see the surgical video, sir.
Can you play the video?
Let me just see if I can share it.
I'm sorry. There's some.
Looks like Sunil sir has gone on mute again.
Yeah, can you hear me?
Yes.
Sir, you are audible, sir.
Yeah, I think go on to the next speaker because there is something wrong with the whole system here. All my computers are shutting down. There are 3 of them and all 3 are shut down. So please
Sure,
go
sir,
on.
no problem. We still saw your excellent surgical videos and that was a great learning. So I invite Dr. Mohanta sir for his presentation. Meanwhile, I just want to remind our discussants and chairpersons for today that you can keep noting on the points from each presenter because we will take the discussion toward end of the session. Sir, you can start, Pradeep Mohanta sir.
Am I audible?
You are, sir.
Okay. Thank you very much for having me. Thank you, Anil sir, Aarti, and everybody. My respect to all of you. I have been given some topics, hydro, what is that, irrigating vectors and other things, fish hook. Let me go one by one. This is the irrigating vectors nucleus delivery. Hydrodissection has been done, and now the nucleus is rotated. And now a good hydrodissection is being done. Nucleus is rotated nicely. And now the anterior chamber is filled up with visco. This is HPMC. And now I'm using 2 hooks to prolapse the nucleus into the anterior chamber. I place one hook under the nucleus and I rotate the nucleus with the other hook and it comes into the anterior chamber. And now I'm using irrigating vectors for some cases, and then I'll go to other techniques. Injecting visco both above and below the nucleus. And this irrigating vectors is attached to a drip set. It is attached to a bottle, and very gently the nucleus is delivered. And now we will see another case where the whole nucleus may not come out at one shot. But this is the second case. Capsulorhexis has been done. And now hydrodissection also has been done. And now prolapsing the nucleus into the anterior chamber. And now inject visco both in front and behind the lens to protect the corneal endothelium and to make room for the irrigating vectors. And now here goes the irrigating vectors. And now see what happens. The nucleus breaks. Soft nucleus breaks at the wound. And now I inject visco and orient the heminucleus which is remaining in the anterior chamber in such a way that it comes easily at the second attempt. So here goes the irrigating vectis again, and it comes out. So there will be some cases where the nucleus will break at the wound, and we have to do it in this way. And this is a very hard nucleus, and the rhexis is not actually adequate, little smaller rhexis. So this is again the two hook technique. One hook below, the other hook rotates the nucleus, and it comes out in the anterior chamber. And again, the endothelium is to be protected. Visco again in front of the lens and behind the lens. And now see what happens as I use the irrigating vectis. It is attached to a drip set, so I don't have to push a piston of a syringe. And the irrigating vectis goes behind the lens. Sorry, it is getting delayed. It goes behind the lens, and the nucleus is stuck at the wound. The wound is maybe just adequate or little small. What to do now? So inject some visco, and I take a Sinskey hook and try to dial the length at the wound. It doesn't come out. So I push the lens from behind and engage it in the tunnel. And now I come to the wound and dial the nucleus. And it comes out. So with irrigating vectis, these three things can happen. It may come out easily. The nucleus may break at the wound, or it may get stuck. And if sometimes it may not come out at all, so we have to enlarge the wound in those cases. And now let us go to other technique, the fish hook technique. This is hydro expression technique, or not hydro expression, visco expression technique. Here the visco is injected, and by the visco pressure, the nucleus comes out. You just have to press the posterior lip of the wound. Sunil has shown this very nicely, so I need not go into details of this. Sorry. And now we'll go to the fish hook technique. So the hydrodissection has been done. And now I have to prolapse the nucleus in the anterior chamber. No, hydrodissection is being done. And by hydrodissection itself, sometimes the nucleus comes out of the capsular bag and comes into anterior chamber. We can see this is a very hard nucleus. Prolapse the nucleus in the anterior chamber. The wound has to be adequate when we use fish hook. Again, visco both in front and behind the lens. We have to make adequate room behind the lens. And here goes the fish hook. It goes and turns 90 degrees to hook the posterior pole, and it comes out easily. The fish hook technique I learned from Dr. Hennig of Lahan, that Sagarmatha Eye Hospital long back. This is the just thinking of the role of pre-chopper in SICS. Here I'm going to divide the nucleus into two heminuclei by the pre-chopper. The nucleus is divided in the bag. The two heminuclei should be completely separated. And now visco, and on heminucleus is brought out of the capsular bag in the anterior chamber. And it is oriented in such a way that the long axis is from the main wound to the opposite equator. And now I am using enlarging the wound and using a fish hook to remove one heminucleus and then the other heminucleus. Here goes the fish hook, and it comes out. Similarly, the other heminucleus also comes out. Thank you very much.
Thank you so much, sir. It feels like I'm watching some very interesting movie on SICS, and the talks are just getting interesting and interesting. Thank you so much for keeping in time as well. Next, we would like to invite Dr. Shekhar Paranspe, sir, for his presentation.
Yeah, I will share the screen now.
Mohanta, sir, request to just stop the screen share from your end.
Good evening, everybody. I'm extremely thankful to Dr. Anil Shah, President of Maharashtra chapter of ISMSICS, for giving me second time this opportunity. You cannot start screen while other participant is sharing.
No, sir. Maybe you can try it now. Sir has stopped it now.
Shall I share now?
Yes, sure, sir.
Yes. Yeah, I believe, yeah. My topic today of presentation is visco-free SICS, a boon of AC maintainer. I'm Dr. Shekhar Paranspe from Sangli. In initial days of IOL, in 1980s onward, most freely and abundantly available anterior chamber maintainer was air. Present day generation of ophthalmologists will not believe that air could be used to form the AC. But in those days, what we used to do, we used to take for ECC 2-3 side sutures, and in the central part of the area, we used to inject air. But as in those days, hypotony was the key word for cataract surgery. Air used to stay put inside the anterior chamber, and we could manage to implant. What I use the term manage, because every time it was not so easy to do. Why air was used in those days? Viscous material like what we use HPMC or hyaluronic acid was not available in those days. Only Dr. Daljit Singh from Amritsar used to formulate through his sources his own HPMC. Hyaluronic acid was available at rate something like 1800 rupees per syringe, that way back in 1980s. At that time, cost of IOL surgery in our hospital in Sangli was around 500 rupees. That includes IOL cost, surgery and indoor stay and everything. So it was obviously 1800 rupees as a viscous OVD material was out of question. In those days, concept of continuous curvilinear capsulorhexis and in the bag implantation was not there. In fact, it was not formulated also. So can opener capsulotomy with ECC and placing the oil behind the iris somehow was the main aim of the surgeon. Around 1985, I must pay due respect for viscous material that was made available by Dr. H.M. Shah of Shah & Shah. My father requested him to come out with injection HPMC, and then he come out with the injection HPMC by the name Visilon. Then onward, as was mentioned by my father, when he for the first time used Visilon, the thrill of ECC and IOL implant surgery was gone. By thrill, he meant anxiety and stress was grossly reduced. So the surgery became very easy. That was actually, I believe, a turning point. Though injection HPMC is very good, it's freely available now, easy to use, low cost, it is not necessarily 100% safe. HPMC has its own drawbacks and limitations. So the antechamber maintainer came into the picture. Dr. Blumenthal from Israel, he was the first person to develop AC maintainer. He used to call it as a third helping hand. That AC maintainer has a one opening with a bevel up tip. Our own president, Dr. Anil Shah, I am very much thankful to him for coming out with a very, I will show you the picture also afterwards. His AC maintainer has a round tip, so it is very safe to use. Regarding the use of AC maintainer, there is one rule that is a strict rule. AC maintainer is first to go in and last to come out. Once you follow this principle, the use of AC maintainer in cataract surgery is very easy. Same principle holds true also for vitrectomy surgery. Irrigating port is first to go in and it is last to come out. Now I will be showing 3 video clips, one after another. First is the standard SICS surgery. I'll start the video now. This is a standard procedure. Now here, with the help of 20 gauge keratome, inferior side port incision is made. Then this is a Dr. Anil Shah's estimate. It has got blunt tip, it goes inside and it stays put there. Side port, and through the estimate, and now at this moment, I will raise the bottle height. Now the girl here is raising the bottle height so that chamber is continuously well formed. You can very easily do continuous curvilinear capsulorhexis. Till now, I haven't opened the main wound. So you can fashion the size of the capsulorhexis as you want. Only little innovation or drawback of this is that the capsule is very freely floating. Now here with the help of 2.2 millimeter keratome, I am entering the AC. I haven't extended the incision right now. Now what I am doing is the heterodissection, standard heterodissection. Now as the nucleus has popped out, second side heterodissection, and now what I am doing, while bringing it out, the girl here is pinching the irrigating fluid. By that, vitreous pressure pushes it out. Now, after seeing the nucleus size, its thickness, its hardness, now I will extend the incision, just optimum enough to bring out the nucleus. With the help of irrigating, with the help of Vectis, the irrigation is from the AC maintainer itself. The nucleus has totally come out. Now you will see it's just one entry cortical irrigation aspiration. Irrigation is through the AC maintainer, and you will see with such a quick snap, all cortex is out. I have just entered once, no second entry from here and there. I always use a cartridge to introduce folded intraocular lens, though incision is quite big. Now still AC maintainer is there. This will last even after removing the speculum. I remove the AC maintainer. That much last. So first to go in and last to come out. I always like to close the conjunctiva with 10-0 nylon. Just 3 throws, no second knot, and cut the suture at long. So usually after 3 to 4 days during eye movement blinking, these sutures comes out. You need not have to remove it. But I always like to oppose the conjunctiva completely. Now we'll go to a second video. This is for the intumescent cataract. I believe I am audible nicely.
Sir, you are audible.
Okay. So here the fluid is too much inside, but I will do first small capsulexis. So what irrigating fluid is doing here, it is clearing the fluid and then my visibility is still maintained. Once this is done, I will totally empty the capsular bag with the help of aspiration cannula. You can see how much fluid is coming out, milky fluid is coming out. And now I will extend the capsulexis a bigger size with the 26 gauge bent disposable needle. Besides this technique, AC maintainer has n number of advantages. You keep on mentioning it, and at least 15 advantages at a go I can tell, but right now the purpose of this presentation is just to show the video films of different technique. Now I will go to a third video film. Here it's a rigid mid-dilated pupil. Such type of pupil, 6 or 7 millimeter, may be good for phacosurgery. You need not have to dilate it more with the hook or anything. But bringing it out the nucleus from the capsular CCC as well as pupillary size, sometimes it is very difficult. So I want physically to dilate the pupil, and that is how I will be doing now. I will use, this is a 26 gauge disposable needle, just 1 millimeter behind the limbus. This is for iris hooks. These iris hooks are manufactured or done by me in our own hospital. They are on par with any other. See now, this is the iris hook which I have manufactured myself from out of 5 or 6 O polypropylene suture. One iris hook is gone inside. Now second will also go. If you go much behind the limbus, then iris tenting is not there. The iris is dilated flush to its plane. Now this is the fourth opening, 26 gauge. Now I have bent it. 26 gauge disposable iris goes inside, and you can comfortably dilate. Now rest of the procedure of CCC and bringing out the nucleus and cortical aspiration is one and same. Is visco-free cataract surgery difficult? In a way, yes. If you haven't learned it, and if you are already well versed with viscosurgery, then you find it difficult.
Rahul, can you please mute people, those who are not? Can you please mute Dr. Gonzalo? Yeah.
For shall I continue?
Can you please mute Dr. Gonzalo? There's some disturbance from his end. Yeah, and please mute people, those who are not talking. Shekhar sir, we would like you to summarize. I mean, no problem.
Yeah. For those who have fully adapted to viscosurgery, this may be difficult. From the day one, if his student is introduced for SICS surgery with AC maintainer, then he will find it very easy. One can use hybrid technique, like sometimes using visco in some steps and otherwise, but at the end of the surgery, AC maintainer should be on. Sectioning of nucleus can be used but I haven't used that right now, the sectioning with snare, but that is also possible, I believe. There are some limitations of AC maintainer. It may slip out. It may come in the pupillary area. Negotiating the nucleus outside the capsular bag may be difficult, and it may poke the anterior capsule also. So in conclusion, is surgery with AC maintainer is one of the different techniques of cataract surgery. I feel everyone should ponder over this question before coming to a personal conclusion. To me, AC maintainer surgery is better. Right now, 80% of my cataract surgery, SICS and phaco's are with the help of AC maintainer only. Thank you very much.
Thank you so much, sir. Next, I would like to invite Dr. Ranjit Dhaliwal, sir, for his presentation.
Aarti, one request. After Dr. Ranjit, can I just finish up the 2 minutes of my video?
Yes, sure, sir. Sure, sir. Yes, sure, sir.
Good evening, everybody. Thank you, Dr. Anil Shah, for inviting me over. Thank you, Aarti. Thank you, Maharashtra chapter. And I'll be sharing my screen now. Just a second. I'm stopping the sharing and I'll be coming back again. So
I already stopped my sharing.
Thank you. I'm starting my video and this has sound in the background, so I'll not be speaking anything myself.
Hi friends, greetings from my infirmary, Nabha. The operating surgeon in all these videos is Dr. Kunwar Vikram Singh Dhaliwal.
We can't see the video, only folders are seen. Dr. Ranjit.
Okay, just a second, please. Just a second. I'm stopping the sharing again. And
so maybe you can just open the video before you share your screen.
Okay. Hi, friend. Can you see it now?
Yes, sir.
Hi friends, greetings from my infirmary, Nabha. The operating surgeon in all these videos is Dr. Kunwar Vikram Singh Dhaliwal. We shall be presenting here visco expression of the nucleus in manual SICS. We prefer to do manual SICS over routine phaco emulsification due to more stable chamber and lower fluidics. In the former, the control over neutralization of corneal astigmatism is much better. A very controversial point, we prefer to perform a gentle but complete hydrodissection, in one go, followed by aiding the prolapse of the lens matter with visco cannula. An incomplete hydrodissection and then playing tug of war with the cortex is more hazardous sometimes. If PC defect is not present, a gentle hydro won't harm. If PC defect is present, it never leads to extension. This is a diabetic cataract in a young patient being taken up for manual SICS. A gentle hydrodissection is done with a 26 gauge cannula and the nucleus is tapped on the opposite pole to release the trapped fluid. Gentle pressure over one pole tumbles out the whole nucleus out of the bag into the anterior chamber. Our preferred technique of nucleus delivery is visco expression, which requires the least number of instruments entering in the AC and is least traumatic to the endothelium. The AC doesn't collapse at any step in this technique. This is a case of manual SICS being taken up under topical anesthesia. Hydro procedure is done under the iris, so not visible. We aim for ample hydrodissection. Tap the nucleus on the opposite pole. As soon as one pole prolapses out of the bag, tumble out the nucleus with the same cannula. It's a totally safe technique for a small pupil and where you have a reasonably large intact rhexis. This is a case of phacomorphic glaucoma, in which the biggest challenges were the white cataract and the shallow AC. The anterior chamber was stained with trypan blue and a gentle hydro procedure was carried out to debulk the cortex and prolapse the nucleus into the anterior chamber by cartwheeling it out. Visco expression was performed to remove the nucleus finally. In this clip we are dealing with a rock-hard black grade 5 cataract and posterior synechia eye all around the pupil. Such cataracts are always accompanied by lax zonule. A gentle hydrodissection is performed with a 26 gauge cannula and the nucleus is tapped on the opposite side to release the trapped fluid. With slight curvilinear movement of the cannula, the nucleus is released of any adhesions it might have with the corticocapsular covering. The same cannula is used to partially cartwheel out the nucleus into the AC. Visco is injected all around the nucleus to build up visco pressure in the AC. The visco cannula is then slowly withdrawn and the lower lip of the corneoscleral tunnel is pressed to help engage and slowly visco express the nucleus out of the AC. In this case we did not attempt the rhexis at all. Rather we directly proceeded to the main entry with the same keratome and we punctured the capsule and debulked the cortex. Following this, the rhexis is completed with the Vanna scissors and rhexis forceps with envelope technique. Hydrodissection is very gently performed and one pole of the nucleus is prolapsed followed by cartwheeling. Finally the nucleus is removed from the anterior chamber by visco expression. The technique is very safe and endothelium friendly. Note that there was no loss of the anterior chamber at any point. Iris was not touched or teased. Injury to the iris in such cases leads to increased inflammation, the next post of day. There is no stress on the already weak zonule. Irrigation aspiration is performed with a lower bottle height. Cortex is irrigated and most of it is expressed out. Do not try to pull the cortical fibers before the IOL implantation. In this video we are dealing with a rock-hard black cataract and a ready-to-construct pupil. Both these conditions are a nightmare for any cataract surgeon, particularly phaco surgeons other than the masters. Such cataracts are always accompanied by lax zonule. The corneoscleral tunnel is made with a crescent blade and a side port is made with a 15-degree knife. Closed chamber, circular curvilinear capsular axis is performed and keeping in mind the size of the nucleus, the radial nicks are given all around the rhexis margin. The anterior chamber is entered with a 2.8 mm keratome. The nucleus tumbling technique in real time. A gentle hydrodissection is performed with 26 gauge cannula. The nucleus is tapped on the opposite side to release the trapped fluid, and the cannula flips the nucleus out into the anterior chamber, partially. At this stage we shift to visco cannula. Visco does not let the anterior chamber collapse and has a cushioning effect on the PC as the nucleus is prolapsed out of the bag. Nucleus is delivered by visco expression. This reduces the repeated entry of instruments into the chamber and does not allow the anterior chamber to collapse at any step. Now the same procedure is demonstrated in slow motion. A gentle hydrodissection is performed with 26 gauge cannula and the nucleus is tapped on the opposite side to release the trapped fluid. With slight curvilinear movement of the cannula, the nucleus is released of any adhesions it might have with the corticocapsular covering. Having done so, the same cannula is used to flip and tumble the nucleus out of the bag and partially into the AC. The hydro cannula is then exchanged with a visco cannula to inject visco all around the nucleus and to build up visco pressure in the anterior chamber. The visco cannula is then withdrawn slowly, and during this procedure the lower lip of the corneoscleral tunnel is depressed to help engage and slowly visco express the nucleus out of the anterior chamber. The key here is how you flip the nucleus out of the bag partially, dislodge it and make it somersault around the cannula like the gymnast uses the support of the rotary movement of the arm of his trainer or coach while vault jumping. The buildup of pressure in the anterior chamber with visco, depressing the lower lip of the tunnel to get the nucleus out, makes it a very minimal tissue handling procedure. And there is very less repeated entry of instruments into the anterior chamber. Thanks for watching. Regards from my infirmary, Nabha.
Thank you. At the onset, let me thank Dr. Anil Shah, President, Maharashtra Chapter, Dr. Buramani, Chairperson of ISMSICS, and all the faculty. I today share my technique of nucleus expression, that is retro-expulsion of nucleus. We all know that nucleus expression is one of the most important steps of cataract surgery. A few things that we have to know is the size of the capsular axis and the size of the nucleus. We began with this technique. As I said, you first judge your incision. Most important part is your wound construction, the length of your incision, and the extent of your incision. Both of these will determine the final outcome of your surgery. We take time constructing the wound because we want a good valve. And as this nucleus is slightly hard and brown, you can see we have gone slightly sideways. The second most important step is the capsular axis. We use the intracameral air bubble Blurex or Teflon blue technique of capsular marking, wherein we fill the air bubble and then inject Teflon blue, get the desired size of the capsular axis. One thing I want to highlight here, especially in SICS, the size of capsular axis is very important. If you do not have an adequate size capsular axis, you land up in complications. Most of the problems arise due to small or inadequate size capsular axis, because we have to get the nucleus in toto in most of the techniques outside the capsular bag. So if the size of the capsular axis is not adequate, you might land up with zonular dialysis, you might land up with PC tear, or you might land up with the whole nucleus and the capsular ring getting dislocated. So take time making your capsular axis and see to it that you are confident about the adequate size of the capsular axis. Once you do your capsular axis, you do hydrodissection and gently rotate the nucleus out of the capsular bag. So one major hurdle has been taken care of. Now you have to deliver the nucleus. This technique we do not use too many instruments inside the eye because then the wound volume gets occupied by the instrument. We just engage the nucleus and push it from behind. So you engage the nucleus by increasing the pressure inside the anterior chamber and then push it from behind. So the main wound is not occupied with other instruments. So the size of the instrument, the size of the wound can be calibrated to the size of the nucleus. Now we have, over a period of time, started using your aerating fluid as the pressurizing mechanism. So here we inject irrelobisco, engage the nucleus inside the wound, and then to pressurize the chamber, we are now using irrigating fluid. These instruments we use in our routine cataract surgery. So here, this is a bimanual irrigation. And then you, from behind, you just push out the nucleus. So your main wound is not used for any other instrument other than the nucleus coming out. So you can titrate the wound size to the perfect size of the nucleus and keep the wound size limited. This will give you good post-op astigmatic control. This is a white cataract. Again, we roll it out of the capsule and then we are using just irrigation. By irrigation, we are pressurizing the chamber and nudging out the nucleus. The same instrument we use for your cortical cleanup, your PC, your anterior capsule polishing, as well as polishing the PC. So simple hydro pressurization of the anterior chamber with irrigation fluid and using the main incision only for the delivery of the nucleus. Once you finish with your cleanup, you can proceed with capsular polishing and lens implant. This is a small pupil, a white cataract. To make an adequate size capsular axis, do your hydro procedure, get one pole out, rotate or dial the nucleus so that you get one clear pole out, and then gently dial it out of the bag with your disco cannula or a Sinskey hook. Remove the loose epinucleus. And again, we will be using the technique of retroexpulsion with the use of irrigating fluid to pressurize the anterior chamber. Here you see the irrigation on, which is pressurizing the anterior chamber, and you gently push the nucleus out. So your main wound is used only for the nucleus expression, and it is not occupied by any other instruments. And to pressurize the chamber, we use the irrigating fluid. So use of routine instruments, just your irrigating fluid. This takes care of your anterior chamber being well formed, and you can complete your procedure without causing much damage to the endothelium and much distortion of the wound. Thank you.
All. At the outset, I wish to thank Dr. Anil Shah, sir, who is the president of Maharashtra chapter of ISMSICS. It is very happy to note that I have been involved as a discussant for this important webinar. And I also welcome Dr. Rohan, Dr. Rajita, and Dr. Gonzalo for being co-discussants on this particular topic. So to begin with, I would like to first give a brief review about Dr. Sunil Tangaraj's video. So he has got very excellent skills in bringing out the nucleus with the help of Sinskey hook. So by tumbling one pole, it's a very, very nice technique. But not all nuclei do tumble like the way what he has presented. And I would still advise people to use, say, 2 Sinskey hooks. But I will share my own technique. I use 2 Sinskey hooks. First, after the hydrodissection, to rotate the nucleus within the capsular bag so that all the capsulocortical adhesions are released. So once the nucleus is rotated clockwise and anti-clockwise, the nucleus becomes more easy to tumble out into the antechamber. Then, if a single pole is to be lifted, a single Sinskey hook would definitely help. And regarding the second technique of Dr. Tangaraj, regarding use of sandwiching with the help of 2 dialers, I use another technique by, we use an iris spatula where I engage the one pole of the nucleus at the equator and then dial the nucleus. That's what we call it as a tire wheel technique. So each surgeon is comfortable doing his own techniques. We do not advocate anyone to practice what you see on YouTube or by a surgeon. You should first try it. Once you're comfortable, then definitely go ahead with that particular technique. It may be working well with you. There is no one single uniform technique, as Dr. Pradeep Mohanta said, that as many surgeons are there, as many techniques are there. And coming to Dr. Pradeep Mohanta's surgical skills, he has been a very, very excellent presenter, doing so many YouTube videos. And his fish hook technique is definitely a very, very wonderful technique in the safe hands. And it would be a nice thing to watch Dr. Pradeep Mohanta sir operating with the fish hook technique. And coming to Dr. Paranjape sir's AC maintainer technique, I had happened to visit Vitala Institute of Ophthalmology in Bangalore, where we first had Dr. Michael Blumenthal from Israel, and he presented his technique of using the AC maintainer and even the nucleus delivery by his scleral tunnels, the scleral pockets that he used to make in the scleral tunnel. It was a very, very excellent technique, and I appreciate the increasing the bottle height, what Dr. Paranjape sir has been practicing, but we need to have a little better control over the antechamber and the use of IC maintainer. And I'm really wondering how the assistants are being communicated by the surgeon as to when to pinch the IV drip set and when to make the AC deeper by increasing the bottle height. And then coming to Dr. Anil Shah sir's AC maintainer, it's a really wonderful technique. Coming to Dr. Paranjape's hybrid technique, which he was recommending for the residents. One is by using AC maintainer, and second one was by the nucleus fracture. So that has been a good technique for early learners, and he is using his own polypropylene suture, and he makes it, the self-made iris hooks, so to keep the pupil well dilated, and the use of sutures, three throw sutures, so that the conjunctiva is approximated. So I have made a novel technique. We follow a novel technique where we use the heat cautery and try to approximate the two conjunctival ends and the cut ends, and just use the heat cautery so that the suture can be avoided, and as well it gives a significant wound cover. And coming to Dr. Vikram, Dr. Ranjit Daliwal's technique. So he uses a single visco cannula, and he calls it as a endogenous endo expression of the nucleus. The tumbling mechanism is really wonderful, and the cartwheeling that is being done, it just simply follows the nucleus to get it into the antechamber. And coming to Dr. Sanjay Tekavade's technique of retropulsion of the nucleus, I just casually remember, imagine somebody is climbing a wall and he tries to just climb the wall, and if he has reached halfway through, there's a person at the ground level who is trying to push him up, and that is exactly the situation what is being seen in this retropulsion of the nucleus. And I really appreciate that technique. It can be of help when the nucleus is totally engaged within the sclerocorneal tunnel, and just little push from the side port wound would definitely get the nucleus out of the sclerocorneal tunnel. Thank you very much. Thank you for giving me this opportunity.
Instead of using repositor, I push it with a Sinskey hook through the side port. And this technique has been nomenclatured as endo expression of nucleus by Dr. Kumar Vikram Singh Dhaliwal. Now, the advantage of using Sinskey hook is that if your wound size is not adequate, the nucleus cannot come out totally. But because of the sharpness of the Sinskey hook, it gets fractured into the scleral tunnel. That is the advantage. And this, all the force is borne by the walls of the scleral tunnel and not by the endothelium. It's an excellent technique, and everyone should try. And it's very simple technique. Then I am very much fond of AC maintainer. I have been using AC maintainer not in 90%, but in 100% of the cases. AC maintainer has got tremendous advantages. Even you can continue installation of the topical anesthetic during the surgery. I am doing SICS under topical, but during surgery also, if you feel, you can instill topical, because AC maintainer will not allow the drug to enter the eye. It will have only the surface action. Dr. Paranjpe showed that he was raising the bottle during capsule exercise. Generally, I don't raise the bottle unless I feel that the AC is slightly becoming shallow. The reason being, I am doing the capsule exercise through the side port, but I don't insert the MUR totally for creating the side port initially. So before doing the capsule exercise, I insert only half of the MUR, so that instead of 0.9, you have only 0.4 or 0.3 breadth of the side port, just sufficient to pass that 26 or 26 7-gauge needle. It should be adequate not to create folds on the cornea and allow the seepage of the fluid through it, but not a...
Thank you, Dr. Anil Shah, sir, for giving me this opportunity. Am I audible?
You're audible now.
Yes.
Yeah. So learning all the above procedures or other different procedures has become very mandatory in today's era, where the cataract surgery is becoming refractive surgery. So because of want of time, I'll be asking only one question to each speaker. My first question to Dr. Pradeep Mohta, sir, is that what are the indications for using only fish hook, only pre-chopper, and both in combination? Second, to Dr. Sunil, sir, that you had shown the Feco sandwich technique of using two dialers. So do you feel sometimes there is necessity of using dialer along with the vectis? And what are the indications for using those differently? Because I am more comfortable always using the Feco sandwich technique with a vectis. The third question is to Dr. Shekhar Paranjpe, sir. While using the AC maintainer, at what grade of cataract and what stage of cataract surgery do you increase or lower the height and change the flow rate to the drip? Fourth, Dr. Dhariwal, sir, as you are using a single hand and a single instrument, do you always use a superrectal suture while doing the visco expression? To Dr. Sanjay Tekawade, sir, your technique is wonderful, but is it always that you use this technique, or whenever only the nucleus is stuck, that time only use this more frequently? Thank you so much.
Okay. For the fish hook technique, the technique can be employed for any grade of cataract starting from grade 3. If it is grade 2, the nucleus it may cut through and it may not come out. And the wound size should be adequate. If it is not adequate, it may become a disaster. And one more thing is the fish hook should go only up to the center of the anterior chamber. It should not go beyond that. Then you may catch the iris, and it can cause iridodialysis. So this is about fish hook. Anything else you asked?
Pre-chopper. When you use pre-chopper,
Pre-chopper is just an experiment.
When you use in combination.
Pre-chopper is just I'm just starting, and I have done only few cases. It is Dr. Anil Shah's technique is fantastic, but it is done in anterior chamber after prolapsing the nucleus, and this is done in when the nucleus is in the bag. So, but the problem is if it is very hard nucleus, say the nucleus is about grade 4 or grade 5, the posterior plate may not be divided, may not be, there may be some attachment in grade 4 or grade 5. In grade 3, grade 2, this is a fantastic technique. You can divide the nucleus into 2 heminuclei completely, and you can prolapse each heminucleus and bring out each heminucleus through a small wound. But this is just an experiment, and I'm exploring the possibilities of this technique. You can also try if you want.
Thank you, sir. I think we'll get to the responses after everybody has had their say. So everybody can contribute before we get to the responses from the speakers. So I call upon Dr. Gonzalo now to give his thoughts on the presentations, please.
Dr. Amir, he's had a surgery session, so he had to leave the meeting.
Right. So, Dr. Rohan, if your network issues are sorted out, we would like to hear.
Yeah. Am I audible now?
Yes.
Yes, you're audible.
It is raining heavily here in South Gujarat. So I would be brief in my comment, particularly on the issues of using this kind of instrument. Particularly, I'm actually for visco expression, I'm using visco extensively, and sometimes if need be, if the cataracts are like brown and hard, I use Vectis. So I just wanted to have an idea if you have found some problem with the Vectis of different sizes and different shapes. If we put small incision, say for 2 or 3 millimeter, and if we keep that incision 5 to 6 millimeter, see the breadth or width of the irrigation Vectis tip does matter. So and also some Vectis are like shallow and some are deep. Deep it comes out easily. Thickness of that ring is concerned. Now the Vectises are available with the thin ring. So I think it doesn't occupy much space into it, but I just want to know how does it affect size and the width of the and contour of the Vectis. If anybody can explain, because most of the new generations are using the visco expression technique along with the Vectis one. So if
Dr. Rohan, you're breaking up again. I think somebody will take up on your query once everything else is done. So I now hand over to Dr. Aarti to take this forward.
So do you want to take comments from the chairperson, Dr. Amaya, at this stage? So we'll hear from Dr. Santosh Agarwal, sir. So are you there?
Yeah, I am there. Just I am listening everybody.
Yeah, it's good to have a VR surgeon amongst the cataract surgeons.
Yeah.
So we would like to hear your comments. Yeah.
Thank you, Aarti, for your kind words. Good evening, everyone. It gives me immense pleasure to participate in today's distinguished webinar. I congratulate all the ISMSICS Office Bearer, Maharashtra chapter, for the great initiative and successfully organizing this webinar series, that is A to Z of MSICS. Since the last few years, MSICS has evolved and widened its horizons immensely. In the era of FACO and flags, MSICS still stands with its distinct glory and advantages, especially in very hard cataract. Most often, during complicated FACO surgeries, MSICS comes to your rescue and offers quite good outcome. It also has been performed widely in ICAMs, government and private medical colleges, district hospitals, and our peripheral area as well in the developing countries like India. Today, we have learned many techniques of MSICS in diverse scenario by our varied experts. Thanks to all faculties and panelists for their wonderful videos and for enlightening us. I am sure those diverse techniques in SICS today would certainly help all of us to refine our surgical work further. I am grateful to Dr. Anil Shah, Dr. Aarti, Dr. Ameya, and all office bearers of ISMSICS for inviting me to this very distinctive webinar. Thank you all. Thank you very much. Regards. Over to Aarti, please.
Dr. Aarti, can I
Thank
just
you so much.
Dr. Aarti, can I just answer the questions what Dr. Ruchita has asked? Just
Sir, we'll wait. Yeah, we'll wait
Yeah.
for the answers because in the interest of time, let's hear
Okay.
from our chairperson, Dr. Rastagi sir, and then maybe we can take a little bit of discussion more. Over to you, Rastagi sir, for your comments.
Yeah, thank you, Dr. Aarti. First of all, I am very much thankful to the chairman, Dr. Boramani and Dr. Sahu sir, and this Maharashtra State ISMSICS chapter, especially Dr. Shah. Well, I still remember 2018, around 6 to 7 years back, when Haryana chapter was formed, and things have changed a lot, very much in this society, and it is, shining on the horizon. And today's presentations, especially Dr. Thangaraja, where it has enhanced my skill that even with intact conjunctiva or, without doing conjunctive flap, we can do this SICS. Dr. Mohantaj, of course, always, joy to listen. And Dr. Paranjpe sir, Dr. Dhaliwal sir. So all have, present their simplified techniques, easy to learn. But one thing I would say that basically SICS is cataract surgery with SICS is a game where the goal is to have a clear cornea and good vision. But the techniques are indigenous. You can use your own techniques, and every presenter has given his own technique in a wonderful way. So in always my slides that in your queer you have to have one arrow, and that is SICS. Without this, you feel incomplete. So thank you very much. Thank you, Maharashtra chapter, for this.
Thank you so much, sir. We will move on to Marathe sir for his comments, and then we will take comments from Sanjay Tekavade sir and Shekhar sir.
I think it was a wonderful webinar today and galaxy of speakers. A great cricket team where opening batter is there, top order batters are there, lower order batters are there, and then leg spin, off spin, fast bowlers. To take the wicket or stumping. So it was a wonderful presentation by each and everyone that I think all the viewers are benefited by this. There were special techniques by each and every presenter. And everybody felt that my technique is the best. And other technique was a little different from that. So there were pros and cons for each and every technique, like fish hook technique and then AC maintainer. All of that was really wonderful, and definitely the viewers will take their own way how to learn what to do and what they are going to learn in future with the spatial learning curve. I think it was a great webinar. Over to you, Dr. Aarti and organizers.
Thank you so much, sir. So let's take comments from Dr. Tekavade, sir.
Yeah, yes, I want to highlight that what I showed, we purposely plug the nucleus. What we do is we, from behind, we increase the intraocular pressure so that the nucleus goes and gets plugged inside into the wound. So it increases the pressure. So it actually protects your endothelium. It makes your anterior chamber much, filled. And that is not actually, if you get, it's not getting stuck, but we purposely increase the pressure by irrigating fluid from behind so that the nucleus plugs the wound. So the anterior chamber is formed, and then you push it. Dr. Boramani, as he mentioned, he uses a Sinskey hook, but I use a blunting and either a IG suppositor, or best now I'm using the irrigation handpiece. So it is a blunt tipped instrument and just pushes out. So it's safe to the endothelium. So that, and in most of the cases you saw hard cataracts, soft cataracts, it works well. Yeah, thank you.
Over to you, Shikhar, sir, for your comments. Can anybody hear Shikhar, sir? Yes, sir has been raising his hand for some time.
Am I audible, na?
You are, sir.
Yes,
now you're audible, sir.
Use of cartridge during SICS also, where wound is already 6 or 7 millimeter long. The main reason is that when you implant the IOL as it is without cartridge, the undersurface of the IOL, it brushes against the conjunctiva, which may carries with it epithelial cells. Some blood may get pushed to the posterior surface of the IOL and organisms also. So they all remain between the posterior surface of the iris and capsular bag, and they will invite either infection or posterior capsular opacification. So if you use cartridge, then these problems will be grossly nullified. But it's still, if you really don't want to use cartridge while implanting the IOL in a SICS surgery where incision is really big, then you request manufacturer not to supply cartridge so that the price will automatically down at least by 50 rupees. This is one thing. Regarding the iris hook, these are DIY iris hooks which we do it ourselves in our hospital. In 2007, when my son Gaurav was doing post-graduation, I was working on the possibility of making iris hooks, and he gave me one hint that this is how you can make iris hooks. And believe me, what we pay 1,500 rupees or 2,000 rupees for iris hooks manufactured by the manufacturer, they cost zero to us. They really cost zero to us. And on this, Gaurav, my son, he has got Best Paper Award in 2007. So I regularly manufacture iris hooks, and then they are on par with any other iris hooks manufactured by the company. That's all. One question I have to all speakers and all the experts. When the nucleus comes out of the anterior chamber and into the outside the eye, the pupillary size drops down to 6 or 7 millimeter. But since I started using AC maintainer, that doesn't happen. Even you must have seen in my video film. As the pressure is continuously maintained between 20 to 30 millimeter of mercury, the pupil continues to remain fully dilated. Otherwise, in olden days, when I was not using AC maintainer and when only visco was there, the moment nucleus is out, pupil drops down to 6 or 7 millimeter, and then you have to negotiate the cortex blindly behind the iris. If anybody has any specific explanation about this, I will welcome it. Thank you.
The only thing what I feel that you are using so much fluid inside the anterior chamber. Because of that, sometimes endothelial loss can happen. That may be one concern. Means not a big issue, but it can happen to some extent. So much fluid turbulence is there all the time throughout the surgery. That may be one of the concern.
So if you use bimanual, The same thing happens. You're not, as Dr. Santosh said, you're not using fluid continuously, but you're using at the time of after the delivery when the nucleus snaps down. So use bimanual, the iris blows up, and you get a beautiful view of all the cortex. So the chamber is maintained for the limited time of eye. So bimanual also helps here.
So let's take comments from Mohanta sir.
Yes, what I want to say is, it's not that my technique is the best. It's that we respect every surgeon, and if you get good results with your technique, it is a good technique. Yeah, I never say that my technique is the best. But I always try to improve my techniques, and every surgeon wants to do that. Dr. Neto Rosatelli came from Brazil to my place, and he said one thing. I quote his that sentence: "There are as many techniques as many surgeons. Every surgeon has his own technique. So if you get good result after your technique, if you give good vision to your patient, that's a good technique. Never think that my technique is the best technique, but you should always try to improve your technique. You should always try to give good results to your patients." Thank you.
Anil Shah sir wants to say something. So over to you, sir.
Thank you very much, all the speakers who have given their wonderful thoughts and given wonderful knowledge to all of us. In this webinar, our aim was how the total nucleus is removed to the anterior chamber by small incision cataract surgery. And we have called all the speakers who are expert in removing all the complete nucleus through the anterior chamber. Dr. Pradeep Mohanto sir has shown in the back pre-chopper with nucleus fragmentation. That is also a very new and good technique, but it needs a very good expert hand. One other thing I wanted to tell about the anterior chamber maintainer, which Dr. Shekhar Paransway said. I don't want to boast about my anterior chamber maintainer, but it is one of the best anterior maintainer chamber. If you use it, you will love it. The main advantage is that you can use it through both the side ports. You can interchange it from one side port to other side port, and there is no need of extra side port. And it has got two side holes, so the irrigation is circumferential. You don't get a single flow in the center. So there is no turbulence in the anterior chamber. Then another important point which everyone is saying, the Sinskey hook we are using for removing the nucleus and Sinskey hook passing below the nucleus. So I think Sinskey hook passing below the nucleus for delivering the nucleus is little risky because it's a blind procedure, and you can there are chances that you can definitely damage posterior capsule accidentally. So for that purpose, I have developed a ballpoint manipulator which has got a smooth ball which can go below the nucleus, and from below you can lift the nucleus, and with the above Sinskey nucleus you can prolapse the nucleus into the anterior chamber. That is one of the safest way. Now, third important thing is we have seen various types of vectis. They are all thick vectis, shallow vectis, they are loop type vectis. And in 90% of the time, when we try to remove the nucleus, sometimes the nucleus tumbles in the vectis and it goes through the vectis and it doesn't come out. So this is my new design vectis which I am preparing. It has got a half cover and the front part is open, and it is like a hollow boat like. So the nucleus sits into the vectis and you just pull the vectis so the nucleus comes out, and the nucleus doesn't fall into the anterior chamber, and extra epinucleus and cortex material also comes out through these openings. And so there is a thin nucleus which will come out to the small incision. This is a 2 millimeter vectis which I am designing. It is still in the process. That is I wanted to highlight. Thank you all the speakers for giving their wonderful thoughts. Thank you very much, sir.
Thank you, sir, for having us.
मराठीमध्ये त्याला झारा असं म्हणतात. तो अर्धा झारा आहे.
Zara only. But that Zara is not looked after. So now we'll come out with this Zara.
Thank you, sir.
Thank you, everyone. So Anil Shah, sir, should I give vote of thanks in interest of time? Yeah. So I know the discussion is going on very interesting, and we still have so many questions which have not been answered. So apologies for the questions to left be unanswered, and maybe we can take up questions in the part B of the similar topic. I would like to thank the Maharashtra chapter of ISMSICS office bearers, speakers, our discussants, and chairperson for this session. A special thank to Dr. Anil Shah sir for his consistent effort and Dr. Prakash Marathe sir for being the motivating force. I would like to thank Dr. Ameya for moderating this session so very well. I would like to thank the team NTOD for all the technical support. And last but not the least, I would like to thank our audience for motivating us to continue this webinar series. So thank you, everyone. See you soon in the next session.
Thanks to you, Arti.
Thank you.
Thank you.
Yeah.
Thank you.
Thank you.
Thank you
Thank
so
you,
much,
Dr.
sir.
Arti.
Thank you,
Thank
Aarti
you.
and
Thank
Ameya,
you.
for your wonderful conduction
Yes.
of this
Ranjit sir,
webinar.
one question to you.
Yes.
What's the meaning of Nava? Nava means sky, isn't it?
No, Nabha comes from the umbilicus. Nabha.
Mm-hmm.
Umbilicus. Okay.
Nabi.
Okay.
And there's a small announcement that I've got to make, if you allow me. Pradeep would be there. ISMSICS Punjab chapter in association with Adesh University under the aegis of Punjab Ophthalmological Society and Bathinda Ophthalmological Society welcomes you all to its annual meet. And this will be the third now. And we have named it CCC for this 2024. Block your date, September 28th and 29th. And we are looking forward to welcome you all at the academic extravaganza, live surgical sessions, motivational pep talks of the masters and wet labs, and much more.
Thank you, sir.
Looking
Thank you
forward to
for
have you
inviting
all,
me.
and looking forward to have you with us, Pradeep. And I would request all our friends to make it convenient to join us there. Thank you.
Thank you, sir, and best of luck.
Thank you.
Thank you.
Thank you, everyone.
Thank you, everyone.
Good night.
Thank you, sir.
Thank you.
Thank
Good
you.
night.
Good
Good
night.
night, each and everyone.
Thank you.
Thank you.